We started very many years ago, I think about 15, in a protocol for elderly patients, or the worst category of patients. Just to remind ourselves that in the past, Philadelphia positive ALL was the worst condition you could get in hematology and maybe even in cancer. So we designed a protocol many years ago for elderly, so that's even worse, because to treat a 70-year-old, 80-year-old with a Philadelphia ALL was palliative treatment very often. So we decided to do a protocol for the over 60s with no upper age limit, which was based on only imatinib, so the first generation TKI, plus steroids in induction. And the surprise was that literally all patients went into hematological remission. I'm not saying they were cured, I said they went into remission, which in those days was an exceptional result, and we had no losses in induction, so there was no death in induction. But that was the starting point of a long story. It went then to second generation, Dasatinib, then we tested nilotinib, then we tested ponatinib. We're keeping the same philosophy in induction treatment without systemic chemo. We had CNS prophylaxis, we added steroids, but if chemo was given, it was given after induction. So this has built up, and the data have been rewarding because we kept on seeing hematological remission in virtually, let's say, between 95 and 100% of patients, and we've never lost patient in induction, so it's non-toxic. Obviously, you have to consolidate after that, so that's an open question. So the protocol we're talking about now is a further step forward, because over the years things change, more drugs come in the scene, and one in particular was of particular interest to us in ALL, not only in Philadelphia positive, and this is blinatumomab, this bispecific monoclonal antibody, which is a form of immunotherapy, because it's a bispecific in a sense that it targets an antigen present on all B lineage ALL with the CD19, and then the anti-tumor effect is mediated by the host, by the patient's CD3 positive T lymphocyte. So it's a form of immunotherapy triggered by this antibody and directed against the B cells which are targeted by CD19. So this monoclonal antibody is of interest, and there have been data over the years it's developed, and it's led to the approval first for relapsed refractory ALL, B lineage ALL obviously, and more recently even for MRD. So we designed a protocol which was based again on dasatinib. We kept the second generation because we thought it was adequate, and we had long data with dasatinib alone. So the induction hasn't changed, dasatinib and steroid. Then as consolidation, we included blinatumomab for a minimum of 2 cycles. And the primary endpoint of the study was the rate of patients becoming completely negative at a molecular determination, or MRD negativity by molecular monitoring. After 2 cycles, that's when we did the testing, we could extend it up to even 5 cycles. And then after that it was open. The centers could do what they wanted, and we would get the data in an ancillary study, and that is what we're doing. So the study was closed recently, and we're presenting for the first time here the data. It's the first ever presentation, as I said, on Sunday morning. And the data are very rewarding, because what has happened is that with dasatinib alone, we've obtained about 25% of complete molecular responses, which is in line with what we'd seen in the past with our previous study. Then after blina, we've seen a progressive increase in the rate of patients becoming molecularly negative, reaching about 65 to 70% of patients, which is an exceptionally high rate of complete molecular response without any chemotherapy, apart from the CNS prophylaxis. So that obviously is extremely important, because again, this study was for all adult patients, 18 up to 70-year-old. I think the oldest was 79, but I'm guessing it's close to 80 anyhow. And they virtually all responded. So that, I think, opens many important points. A, that you can, without chemo, get very high rates of complete molecular response. And I remind all of us that in an acute leukemia, we need to become MRD negative. If not, if you have residual disease, the patient will eventually relapse. So I'm not saying that if you're negative, you don't relapse, but the likelihood that you don't is much higher. That's a key point. Second is that we saw an interesting phenomenon that is very new, that even after the second cycle of blina, we kept on seeing increased MRD negativity. This is very different what is in the literature seen before with full-blown relapse, where the maximum response is after 1 or 2 cycles. So this opens an interesting question on the mechanism, or is this maybe leukemic stem cell? So we need more research. Second point, that we had some patients who had developed in the last days of dasatinib treatment a mutation, a 315 mutation, which may confer resistance to dasatinib. And all patients responded to blina, so we got rid of the mutation too. That's a very important piece of information. So we're very excited of this, and obviously that's not the end of the story, but it's a major step forward. So the next protocol we're working on is what do we do after that, and we're probably going to use a further third-generation inhibitor to try to obtain that. So it's very good news, because particularly to remind ourselves that the incidence of the Philadelphia positive ALL increases with age. So if you're over 50, 60, it could be 1 out of 2 of the B lineage ALL carrying this genetic abnormality. So managing to obtain a molecular response in most of these patients without chemo, which is difficult to give in an elderly patient, is obviously a major step forward. So in the next study, we hope to prove this and probably even to reduce the number of patients going to transplant, which would be good news. So I think, well, I shouldn't say, but we are obviously very happy with the data, and I think it's a major step forward.